This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome everybody to another episode of PHM from Pittsburgh. I am your host, Dr. Tony Tarchichi. In case you're new here, I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We have been coming to you since October of 2016 with these podcast episodes, and I want to just say a big congratulations to anybody who just took the boards last month or this month. I forgot when it was. Glad you're all done, and we hope you enjoyed it and everybody passed. Now, we have decided, we have been going through these American Board of Pediatric Content specifications for a while now, and we are still marching our way through them. We decided to waltz over to cardiology. And within cardiology, which is about 4% of the test, there's a section on dysrhythmias. And dysrhythmias is something that's always been a little bit challenging and something people like to talk about, and it's something we're always worried about as a hospitalist. So I decided to try to cover these. We're going to split them up into two lectures because over the years I've learned a topic like that can't do in one. The first podcast is going to be on this one, is SVT, Supraventricular Tachycardia. Then the second one will be on what I'm calling the others, PAC, PVCs, AV block, all of those. We're going to lump them in together. So in order to do this, I'm bringing back friend of the podcast, Dr. Gaurav Arora. You all remember him from our neonatology cardiology section podcast. Dr. Gaurav is a Med-Peds trained pediatric cardiologist and, in fact, an electrophysiologist. He's an associate professor in the Department of Pediatrics. He's the associate director of electrophysiology here at Children's Hospital of Pittsburgh. He's the associate vice chair for clinical affairs, ambulatory care for the Department of Pediatrics here at Children's Hospital of Pittsburgh. So I couldn't think of anybody better, and I'm so happy you took the time out. So Dr. Arora, thank you very much for joining us.
Tony, thank you for having me. I really appreciate it.
All right. Now, this is for CME. Let's get our conflict of interest out of the way. I'll go first. I have nothing to disclose.
All right. I have a consulting relationship with a firm to do some research EKG reading, but that has no application to the content today.
Okay. So now this is an area that we see a lot, we hear about a lot, SVT. It's always daunting. But for you, this is daily, a regular, everyday kind of a thing.
Absolutely. So SVT is something, as an electrophysiologist, we see a lot, both in the clinic, in the emergency room, and in the EP lab, where we do ablations to hopefully cure SVT. So when I think about SVT, the first thing I think of is the semantics of it. So we talk about it as supraventricular tachycardia, and while the wording would suggest that any arrhythmia arising above the level of the AV node should be classified as SVT, what most of us really mean when we say SVT is a paroxysmal rhythm problem that comes and goes. So patients are generally fine, and then they have these episodes of rapid heart rate, and so we classify them as paroxysmal reentrant tachycardia, or what we call SVT. And to me, clinically, SVT really can be classified in two presentations. One is the SVT in the infant, and the second is SVT in the older child. And I think they have their own presentations and own natural history to talk about.
Now, am I right, just for you all at home, in my preparation for this, I read 3 articles. I know everyone likes to hear about the articles we go through. Gaurav knows all about this, so he obviously is prepared in general. For me, I read, the first one is Heart Rate and Rhythm Disorders in Peds in Review 2017, Volume 38, by Philip Wackel and Brian Cannon. I then read Consultation with the Specialist, Cardiac Dysrhythmias, by John Tingelstad, also Peds in Review in 2001, and Focus on Diagnosis, Cardiac Arrhythmias in Children by Eric Biondi, who's the division director over at Johns Hopkins for Hospital Medicine, Peds in Review 2010. So that was my preparation. But am I right in that the SVT is the most common abnormal tachycardia present in pediatrics?
Yes, that's when we're talking about sustained tachycardia, SVT is the one that we think of the most.
All right. So now I'm going to cede most of my time to you. So however you want to do it, we'll do it.
All right, so let's talk about the infants first. And so infants who have SVT will present in one of two ways. They'll present either because somebody incidentally checked a heart rate and found that they were in SVT. And believe it or not, this is more common than you might think. I have a lot of babies I have the privilege of following in clinic who went for a weight check or a well visit, and when they checked in at their PCP's office, lo and behold, they were discovered to have a heart rate in the 250s. Well appearing, otherwise doing well infant, but just happened to have rapid heart rate. And so that's sort of incidentally diagnosed SVT because it hadn't progressed to the second category where infants will present because they've been in SVT for a while. The heart is like any other muscle. If you overwork it unnecessarily, it will get tired. So they present because they develop left ventricular dysfunction, and they present with symptoms of left ventricular dysfunction, which include lethargy, poor feeding, and can even be so dramatic as to present in cardiogenic shock because they have terrible left ventricular function. And so really babies are unique because they have these two sort of extremes of presentation. Either they appear totally well but just happen to have a very rapid heart rate, or they're presenting because they're symptomatic and families have noticed that they're not feeding well, they're not looking good, they look gray, and they have compromised cardiac output because of their tachycardia.
Can I ask, so the heart rate we're looking for to say SVT in an infant, is it 220 to 270 beats per minute?
That's in the right range. I would even say 220 to 300, honestly. So what I tell parents is that remember your baby's normal peak heart rate with agitation and extreme excitement would be a peak sinus rate of about 220 beats a minute. Remember that in general, in pediatrics, we calculate peak heart rate for an individual as 220 minus their age. So for babies, really, sinus tachycardia can absolutely be up to 220. And so when I counsel parents and I say, look, your baby has SVT, how are you going to know this at home? If you feel your baby's heart rate and it seems crazy fast, how is your baby behaving? If they're super mad, screaming, that's not the time to wonder about whether they're having SVT or not, because what you need to do is calm them down, feed them, change them, love them, whatever you need to do to have them get quiet, and then feel their chest. And if it still feels crazy fast, that might actually be SVT. But by then, if you've calmed them down and it seems more appropriate, 140, 160, then that's probably not SVT. But you're right, 220 to 300 is the range I think of for SVT in babies. And 220 even is a little slow for babies. Most babies will be 240 plus.
Interesting. And what the difference between the kid that will present, the infant that will present spontaneously because someone checks a heart rate versus the one in shock or in lethargy or feeding disturbance, is it, because from what I understand of SVT, kids can go in and out of it. Is it that the child in shock, et cetera, has been in it longer?
Exactly. They've been in it longer. They have no way of communicating this to us, right? So the developmentally appropriate older child will sense SVT and they will tell somebody. So a child who's communicative at age 7, say, will be able to tell somebody they're having tachycardia and they won't stay in it for hours because they will communicate with somebody. But babies can't do that. So if they are in a sustained SVT and it doesn't break on its own and they've been in it for hours, they'll develop LV dysfunction and that's how they'll present.
Okay.
So the other unique thing about babies with SVT is that they have actually a possibility of having the SVT spontaneously resolve with time. So infants who have SVT actually do have a chance of growing out of it, most of them by a year of age, some of them by slightly earlier. Our general approach here at Children's Hospital is for babies who have SVT. We generally will offer parents medication to try and prevent future episodes of SVT. It certainly is a case-by-case decision, but I would say the majority of instances we do treat with medications to try and prevent episodes in that first year of life. And we'll usually take them off their medication sometime between 6 and 12 months of life to see if they have actually outgrown it, period. What I tell families is that there's about a 2/3 chance that their baby will outgrow their SVT by the time they're about a year of age. And obviously the data we have is variable and the percentages are span around that number, but I think that's a good general benchmark for parents to use, that there's a reasonable chance that infants will outgrow their SVT. This is distinctly separate than older children, where if you have a kid who's school age, 5, 7, 10 years of age, who presents with SVT, they are much, much, much less likely to spontaneously grow out of their SVT. And so that's a different counseling that we offer families and patients as to what they can expect with their SVT.
So in an infant, you're more likely to try medical therapy, and I'm guessing it's beta blockers, calcium channel blockers?
So beta blockers and digoxin are the two meds we generally use. Calcium channel blockers are to be used with caution in infants. The infant myocardium is very calcium dependent. So certainly IV calcium channel blockers are generally considered to be contraindicated, especially in neonates, and some would argue during the whole first year of life. Oral calcium channel blockers, in theory, you might use in an older infant, but in general practice, we really don't. We really, for me at least, beta blockers are the mainstay of therapy for infant SVT, and in infants where beta blockers may have other issues or conflicts, then digoxin is another drug that can be used. One of the good trials in our business called the SAMIS trial, SAMIS, compared digoxin to propranolol head-to-head for treatment of neonatal SVT and showed that both were roughly equivalent with equal efficacy of preventing future episodes and equal number of breakthrough episodes in the first 6 months of life. So I think both of those drugs in many centers are considered the first line, partially because the side effect profile is so favorable. I think there are pediatric EP docs around the country, at least that I know, who might use more potent antiarrhythmics like sotalol, flecainide, or amiodarone as therapy for neonatal tachycardia. That has not been our general first-line approach because we've had reasonable success with drugs like digoxin and propranolol that have good safety profiles and are generally very well tolerated.
That's good to know, because digoxin in the adult population, we're always worried about it for the side effect profile. But you're saying in the pediatric population, it's not much different than propranolol. Propranolol, the biggest side effect for infants is really hypoglycemia if they fast for too long.
Right. So what I tell counsel parents about with propranolol and hypoglycemia is that if your baby is not actually going to eat, then that's the only time I truly worry about it. If a baby is taking food, then I've never seen an instance of hypoglycemia. The American Academy of Pediatrics recommendations for treatment of hemangiomas, when you look at their guideline statement about instituting propranolol for hemangiomas, they sort of concur with how I was trained in practice that you don't need to check spontaneous glucoses, and as long as kids are actually eating, they'll be fine. In my career of giving lots of babies propranolol, I've never had kids get hypoglycemic if they didn't have concurrent gastroenteritis.
Okay.
So really what I counsel families on is really just, if your baby develops gastroenteritis, you should not give them the beta blocker and you should call us. But beyond that, they're going to, again, kids who are otherwise normal are going to be perfectly fine.
And so you don't see a difference in more side effects of digoxin versus propranolol?
We really don't. And I think that, in older kids with beta blockers, we'll talk about the idea that we talk about fatigue or the potential for mood irritability. In reality, in infants, it's extraordinarily rare that a parent ever really mentions to me they notice anything at all about a difference in propranolol versus not. And digoxin really has no symptomatic side effects in infants. The side effects we worry about are if you develop renal dysfunction, then you can build up a high level of digoxin. If you have acute renal dysfunction develop, and thankfully that's very uncommon in our otherwise healthy neonates, so that's usually not an issue. So you really can use either drug, assuming, I should say one thing, which is the resting ECG does, for me, pose a dichotomy in the management algorithm. So if your resting EKG shows Wolff-Parkinson-White, then adult data for WPW suggests that digoxin and calcium channel blockers are absolutely contraindicated. The neonatal data is not as clear there, but certainly in my own practice, if the resting ECG shows WPW, I absolutely will choose beta blockers over digoxin. I don't know if that's universal across the community of pediatric EP, but many people would be wary of digoxin because of that. If the resting ECG is not pre-excited or does not have WPW, then I think you have the freedom to choose either drug.
Well, that's great. And we're going to get into WPW a little bit, but since you brought it up, I do want to ask, identifying WPW in an infant with their rapid heart rate on an EKG, it seems like every EKG I've seen with WPW has been an older child or an adult, and their resting heart rate's slower. It seems like it would be harder for the average hospitalist or pediatrician. Do you feel that way?
I do. I think it is tricky. You're absolutely right. So infant heart rates, as we all know, are faster, and so the resting infant in your office might have a heart rate of 120 or 130 or 140, depending on how excited they are about having their EKG. And WPW can be subtle in the neonatal EKG. The EKG appearance of WPW, remember we talk about 3 EKG hallmarks: a short PR interval, a wide QRS, and a delta wave, or a slurred upstroke to the QRS. The EKG appearance is actually the result of 2 things, right? So we all have normal AV node conduction, or hopefully have AV node conduction, where you have a normal AV node bundle and his Purkinje system. And so you have a normal neuro-QRS from his Purkinje activation. And then if you have an accessory pathway that connects atrium to ventricle, then you have a wavefront that goes from atrium to ventricle and starts depolarizing through the ventricular myocardium, and depolarizing through the myocardium is slow. So it gives the appearance of a PVC. So if you imagine what a PVC looks like on a monitor and a narrow QRS, and you add them together, you get the appearance of WPW. You get a P wave with a slurred onset that is the depolarization through the myocardium, and then you get the narrow QRS that follows because that's the His-Purkinje system catching up. Now, babies have really good AV nodes. So as a lot of tissue in their bodies, it's super healthy and super well functioning. So their AV nodes are very brisk. So the part of the depolarization of WPW is very small. And so it is very easy to miss WPW on a resting EKG in babies. And I've certainly seen where I've seen cardiologists read EKGs as normal that indeed had very subtle pre-excitation in babies. So it is hard to see. The good news is, in the big scheme of things, the choice of digoxin versus propranolol for neonatal SVT in many ways is really about probably training and comfort more than it is about hard evidence. As I said, the one trial we have sort of showed them equivalent. Now, in that trial, they certainly enrolled only patients who didn't have WPW because they recognized that electrophysiologists might have hesitation in giving digoxin to neonates with WPW. Again, the data in neonates for digoxin being contraindicated in WPW, I don't think is as ironclad as it is in adults. So there are certainly electrophysiologists I've spoken to who feel very comfortable giving digoxin to neonates with WPW. I just don't know that that's universal. So I think that for the audience, really, I wouldn't sweat too much being worried that, am I going to possibly miss subtle WPW on an EKG? It's conceivable. I think that more than likely for most infants with SVT, you're more than likely going to be employing the help of a cardiologist in some fashion to be seeing that kid and monitoring that kid. So that's something you can work together with your cardiologist on what the right next step is. And again, I find that institutional practice on how to treat neonatal SVT is variable. And some people trained in the school of, the first episode of SVT, we're going to let babies sort of have that as a free pass and just see. My personal approach is, parents of babies have lots to worry about already, right? So you're just worried about your baby and sleeping and feeding and all the things you worry about as a parent of a new baby. So to me, I don't want to add this to the list of things parents have to worry about to say, we're not going to treat your baby with medicine. You just monitor and see if you think there's SVT and let us know. Because to me, that's putting a lot on families. Right. And given that the morbidity of giving them the medication is so low because the medicines are so well tolerated. So quite frankly, what I tell families when I offer the medicine is, look, we could do without, but the medicine is really well tolerated, very unlikely that you're going to notice any difference in your baby when you give them the medicine. So really, it's just about you getting the medicine and you giving them the medicine. And if you can do that, then it's very likely that the medicine will help prevent future episodes. So that's one less thing you have to worry about. And you just worry about giving the medicine. You let me worry about whether or not the episodes are recurring or not.
Now, for those of you at home, if you haven't seen WPW in a while, we were talking about it. 2 out of the 3 articles I mentioned in Peds in Review, the 2010 article and the 2017 article, have very nice examples of WPW. But, Gaurav, a question that just had in my mind is, when you are sending these kids home starting propranolol or either digoxin, do you send them home with a monitor of any type?
I personally don't. There also is no hard evidence there on what the right practice is. Some of my partners will get patient stethoscopes to take home, and I personally don't even do that. What I counsel parents on is, look, if your baby has SVT for 10 seconds, nothing's going to happen. The line I say to parents in the office is, look, if your baby went into SVT right now in front of us, nothing bad or terrible would happen. Okay, so if you have a baby with a normal biventricular heart who has normal function, then if they go into SVT, they will tolerate that for hours and hours. So there's no dire emergency that you have to figure out in the next 10 seconds that's a life or death situation for your baby. So the real concept of medicine is to help prevent sustained, prolonged episodes of SVT from then degenerating to ventricular dysfunction and shock. So really what I counsel parents on is, if you want to just get used to feeling your baby's chest at different times, that's fine. Again, make sure your baby's relatively calm when you do that, because when they're very excited or agitated, at least for me, it's hard to tell the difference between 210 sinus tachycardia and 240 SVT just by palpation. And I tell them, the SVT should be in your mind as one of the things that might be an explanation if your baby is fussy, irritable, and you can't explain why. Now, there are lots of other things that cause fussiness and irritability in babies. We know that. So I tell parents, look at all the usual stuff first. Are they hungry? Are they cold? Do they need to be changed? Whatever. If you get beyond all of that and you're not quite sure why they're fussy, sure, this should be on your list and you should put your hand on their chest. I think that one of the nicest things that hopefully we are good at doing is when babies are in the hospital, if they're having SVT, if they have breakthrough SVT when they start, we want families, hey, look, your baby's fine. This was your baby in SVT and they're fine. Put your hand on the chest, feel what it feels like, because parents will then say, oh, wow, yeah, that's crazy fast. I'm not going to miss that. No, you're not. You really won't. Okay, and so that's what I counsel them at home. I don't send them home with a monitor. I don't send them home with a stethoscope. But people do, and I wouldn't argue that. Certainly in today's world, what's becoming more common is biowearable devices for families to have at home. And so there's some devices that are out there that your baby can either wear on their wrist or wear as a sock and record heart rate. There's pros and cons to that. Just as all of us who grew up in the era of apnea and bradycardia monitors know, there's lots of false positives, although there are true positives. The same thing is true here. And so I have some of the families I have the privilege to take care of. They do decide to get these monitors on their own. And so they'll call me and say, oh, the monitor did this, but I think my kid's fine. I put the hand on the chest and it seems fine. What do you want me to do? And I said, well, look, if you put your hand on the chest and actually felt their heartbeat and it doesn't feel crazy fast, then the monitor is probably not correct to saying it's going that fast. And it's fine to keep an eye on things and see where you go. But we don't routinely recommend that.
Okay. So if I'm understanding this correctly, and I want to make sure I get it, for an infant with SVT, you'll put them on medication to prevent the sustained episodes of SVT because that can lead to congestive heart failure, can lead to lethargy, all the end effects you want to avoid. If they could still have these brief periods of heart rate of 240 lasting 20 seconds, 30 seconds, and it goes away.
They could, and at home, they're never going to know that, right? And so when my personal practice, when I see those babies in clinic, is I'll usually send them home with a 24-hour monitor or a Holter monitor to just take a random snapshot surveillance of, are they having breakthrough SVT or not? The reason for me is, if they're having breakthrough SVT on their monitor, it will raise my awareness of, do we need to change their medical therapy perhaps because they might be on the cusp of being at risk for having a more sustained episode? And so whether their dose needs to be adjusted, I often use that as an opportunity to make sure I speak with parents about, is there any chance we're missing some doses here? Is that potentially at play? Or do we need to make a wholesale change? For us here at CHP, when we initiate therapy for babies with SVT, especially because most babies will present usually in the first 4 to 6 weeks of life, so we will usually bring them in the hospital because we want to make sure that their ventricular function is okay at the initiation of therapy, that they haven't had some ventricular dysfunction to begin with, make sure they tolerate their meds, educate families on what they can expect, because as you can imagine, if you're bringing home a newborn and now you've got this heart thing on top of it, it can be quite frightening for some families. So to help educate them on what to watch for, and then once they've been achieved steady state on their medicine and had no breakthrough SVT, we'll usually send them home. And so it's typical, again, case by case, individual, but typical that a baby with SVT is brought in the hospital would be discharged after a couple of days.
So now if I'm a hospitalist and I have a kid that you're taking care of who's now a few months old and maybe coming in with bronchiolitis, coming into my service, will the fact that they have this respiratory viral illness, which can increase their heart rate with their fevers, et cetera, will that affect, I'm obviously going to call cardiology to give us a hand, but is that something that you know about that they could go in SVT more when they're sick or when they have these viruses, even when they're on the medicine?
It could be, and certainly the other question we get a lot is the use of beta agonists for babies who might need it if you're going to use it. In other words, if you really thought that in a particular baby for some reason, or I get this question probably more often in older kids with asthma, use of albuterol in kids who have SVT. And I say, look, if that's what they need at that moment for their respiratory therapy, then that's what they need, and that's okay. We can always deal with SVT. That's not a problem. And so I don't have a contraindication to using those. And to answer your first question, yeah, I think illnesses and fevers certainly make it more likely. You know, SVT is related to a circuit, and we'll talk about the etiologies of that, but you have to have the substrate for a circuit to have SVT. So fever is not going to just make any infant have SVT, but in somebody who already has the circuit, who already has the predisposition, then certainly that can happen. The same thing happens in hospitalized children, for example, who have metaporsin. So I'll get that consult occasionally that a child has a Metaport in, and then lo and behold, we put a line in this kid, we put an IJ line, the interventional radiologist called, or the Metaport was put in, and now there's SVT. Did the Metaport cause the SVT? And I said, well, again, if we're talking about a re-entrant paroxysmal arrhythmia, clearly abruptly stops, abruptly starts, and it is a re-entrant mechanism, then that child has the substrate for it. Having the port in may have been the thing that tickled it and sort of started it, but they have the substrate. I can't put a port in everybody and make them have SVT. But if you have the substrate for it, that could be a nidus for it. And again, case-by-case decision, but in some of those cases, if the times that I've, again, had the privilege of taking care of some kids who had hemonc issues and had ports in and had SVT with their ports when they were getting certain agents flushed through or high volume or things like that. And for many of them, we've elected to say, look, you have the substrate, but if you're not having SVT at other times, maybe we just keep an eye on this and recognize how do we know when it's happening, and how do you recognize it? How do we teach you vagal maneuvers, and how do we know when you're going to get you out of it? But maybe we'll just keep an eye on it versus considering, do we need to put you on chronic therapy to try and prevent future episodes?
Well, I think this is a good moment to bring back our old joke segment. We haven't done it in a little bit, but the corny joke segment's making a comeback, everyone. So, Gaurav, I know you have one. I'll go first, and then you can go.
Okay.
At what sport do waiters do really well?
I don't know.
At tennis, because they can serve so well.
Nice.
You're up.
All right. In the Star Wars universe, why did movies 4, 5, 6 come out before movies 1, 2, 3?
I don't know.
Because in charge of directing, Yoda was.
That's great. Do you want to move into the older kids?
Yeah. So older kids. Now I separate older kids really into kids who are developmentally normal and those who have developmental delay. And the reason is a child who's developmentally normal and can communicate with you, they will recognize their SVT. Pretty much undoubtedly. So again, when I say SVT, I'm talking about this paroxysmal, abrupt onset, abrupt offset, rapid heart rate, not incessant arrhythmias like atrial ectopic tachycardia or junctional tachycardia that can occur. Those arrhythmias are often asymptomatic. But paroxysmal SVT is very symptomatic, and kids will recognize that this is not a normal feeling. In my practice, I've seen kids as young as 1.5 be able to communicate with parents by touching their chest and putting their hand on their chest that, hey, something's not going on, something's not right here. But certainly kids who communicate, 3, 4-year-olds, will absolutely tell their parents that something's wrong. Now, kids who are very young, 3 to 7 perhaps, they may not have the vocabulary to exactly identify it. They may say, my heart's beeping, I'm having pain, something's hurting, something's not right, but they'll recognize it's not normal because it's a very rapid heart rate, very unusual feeling. And kids who are older than that, so 7 to 18, absolutely recognize the sensation, and they will almost universally complain of palpitations. They will recognize that they have an abnormal fast heart rate. Kids who have structurally normal hearts with normal function, again, will tolerate SVT for hours and hours. So nothing bad or terrible, assuming the school-age child who doesn't have WPW, we'll come back to that and the importance of that later, but they really will tolerate it for a while. So they really are going to present because they sense the rapid heart rate. It's very uncommon for children with normal hearts who have SVT to have such compromised cardiac output that they have acute syncope without other symptoms. So while it's possible, I think SVT presenting with syncope is very, very rare. And in fact, in my entire career dealing with young people with SVT, I can think of only 1 or 2 young people who presented with syncope and SVT because usually they'll come to attention far before that. Again, the developmentally delayed child is different because if you have a child who has significant developmental delay and perhaps is non-communicative, they're going to present with SVT much like infants do because they're going to be in it for a long period of time before it's recognized. Okay. So I've taken care of a number of those individuals where, yes, their SVT does present with syncope because they're in it for a while, they develop some ventricular dysfunction and compromised cardiac output, and then they present with syncope. But developmentally normal kids really won't have that. So in the older child, older than 3, the things that are different than infants is that, first of all, there's a much, much lower likelihood of spontaneous resolution. So what I tell families is the likelihood that this SVT is just going to up and disappear and never happen again is very, very low. So the management algorithms for us in older kids who have SVT, for me, start with what does their resting EKG show? If the resting EKG shows WPW or Wolff-Parkinson-White, it's one algorithm, and I'll get to that. And if the resting EKG is normal and does not show pre-excitation, then it's a different algorithm. The reason for the dichotomy is that Wolff-Parkinson-White, in addition to making you at risk for WPW, because you're in WPW, the way that SVT happens is an electrical impulse goes down the AV node, actually comes up backwards up their accessory pathway and creates a large circuit, and it goes around in a circuit that way. But when you have WPW and you have forward conduction across that pathway, then there's another risk we worry about, which is if you have very rapid conduction forward across that pathway during atrial fibrillation, where atrial fibrillation is this chaotic rhythm where the atria go 400 times a minute, and if you have very rapid conduction forward over the accessory pathway, that can precipitate ventricular fibrillation and can cause sudden death. So in WPW, we quote a risk of sudden death of about 0.1% per year, or 1 in 1,000 per year, based on a couple of natural history studies, including one done here at Children's Hospital of Pittsburgh and published in American Journal of Cardiology in 2013 by Dr. Nicole Kane, one of our former fellows. And we sort of validated that number that had been seen before in the literature, 0.1% per year. Now, that sudden death risk doesn't really take off in young people until probably around age 10 or 11 or older. And so there was a nice multi-center study by Dr. Susan Etheridge out of Salt Lake City, published in 2017, that looked at life-threatening events in kids with WPW. And in those kids, there was, as I recall, if you looked at non-neonates, and there was only one child under the age of 10 in their entire cohort. So if you're a single-digit age child, 4, 5, 6, 8, 9, and you have SVT and WPW, it's still extraordinarily unlikely to be a life-threatening thing for you. Whereas once you get to be a teenager, it is still statistically uncommon, but it is a worry we have. And so our algorithm for teens who have SVT and WPW is that we advocate that we should consider transcatheter ablation for your WPW and SVT because this has the potential to be life-threatening. If you have WPW and SVT and you're a single-digit age child, 5, 6, 7, 8, 9, I tell families to expect that ablation is on the horizon. I offer them ablation at that age because logistically we can do it at that age just fine. However, if they're uncomfortable and not quite ready to send their 5 or 6-year-old, then we can give them medical therapy to try and hold their SVT. But what I tell families is whether we do your ablation at 5 years old or 6 years old or 8 years old doesn't really make a lot of difference to us from a technical standpoint. And so we're happy to do it when you're comfortable and ready that it needs to be done. If you have a normal resting EKG, especially if you have more than one EKG that's normal, then the likelihood that you would have a life-threatening cause for your SVT is extremely low. And that's what I tell families. The wording I use specifically is, with a normal resting EKG and a normal heart, the likelihood that your SVT is dangerous or life-threatening is exceedingly low. As such, we can treat that SVT based on how much it impacts the quality of life for that patient and that family. And we offer those families really 3 options. For the patient who has extremely infrequent episodes, we simply counsel them on how to recognize the episodes. We counsel them on vagal maneuvers and how to do them to get them out of the episodes. And we say we'll just keep an eye on it. I reassure families that we're not harming your child's heart by allowing them to have SVT. We're not damaging their heart for their lifetime. These self-limited episodes that they get themselves out of are quite fine. And if your kid has 2 to 3 episodes a year and they can vagal themselves out in 2 minutes, and everybody involved, the patient, the family, their environment, in other words, the school and the people around them, are all okay with that, that's a perfectly adequate strategy. If, however, the SVT is compromising their quality of life in some way, it's affecting them, then we can talk about 2 other treatment strategies, one being medication and the third being transcatheter ablation, or EP study or catheterization, all sort of semi-synonymous. With medication, what I tell families is that the medication, it generally will control the episodes of SVT, but unlike, for example, antibiotics for strep throat, the medication's not a temporary entity that then results in a cure. The medication really is designed to prevent the circuit, so it only works as long as you take it, and it doesn't permanently cure the problem. So really they have to understand that the medicine is to improve the number of episodes and hopefully prevent future episodes, but it's not a permanent cure. Having said that, again, the medicine is very well tolerated. I personally still choose beta blockers as the first-line medication for SVT in children. I think it's extremely well tolerated by kids. There's some transient fatigue and mood, which is typically goes away by 10 days to 2 weeks. most of the school-age children and adolescents I talk to who take beta blockers, they say they don't notice anything once they've been on it. They still can run around, exercise, do everything they want. They don't feel limited in any way. Extremely rarely in my career I've seen mood disturbance, like I'm talking about dramatic mood shift, like my child became the exorcist, that type of mood disturbance. That's extremely rare. When I mention those words to a parent of a teenager, I almost universally get eyebrows raised, and they look at me and sort of say, yeah, I got a moody kid in my house already. What are you talking about? And I say, look, you've already got enough mood disturbance and mood swing to begin with. We're talking about, again, dramatic mood shifts. And again, I've seen that probably less than 5 times my whole career, sort of dramatic mood shifts on beta blockers. And the last one is the hypoglycemia that we talked about earlier, where I mentioned to families that hypoglycemia can occur usually in the setting of gastroenteritis. So I really just counsel them that if your child develops gastroenteritis while taking beta blockers, you should stop it. The last thing I mentioned to young men is for teenagers and young adults is simply the possibility of erectile dysfunction or sexual dysfunction on beta blockers that can happen. And so in the population of young men who are old enough, I mention that to them so that they're not unpleasantly surprised if they start taking beta blockers and wondering if something's different. And then third is ablation. And I tell families that ablation is curative. We hope to find the substrate and eradicate it. National registries have quoted success rates in the 90 to 98% range, depending on exactly the substrate. The recurrence risk is probably somewhere in the neighborhood of 5 to 10%. So is something that we counsel families above ahead of time.
So I have a couple of questions. One, I want to make sure I have the right heart rate. So for older kids, we're talking 180 to 240 beats per minute to call it SVT. Is that right?
Fair. What I talk about with rates is, because again, these days, especially with biowearables, with Apple Watch, with Fitbit, we get a lot of consults. Oh, my heart rate was X. Do I have to worry it was abnormal? And what I say is there's an overlap, right? So again, we go back to our calculator, 220 minus their age. So for a school-age child, a 10-year-old perhaps, their peak sinus rate might be about 210 beats a minute. SVT is commonly going to be between 180 to 270 range. And so there's really overlapping bell curves. And what I tell families is if the heart rate was 150, it's almost certainly normal. The likelihood that was SVT is very, very low. If the heart rate was 250 correctly taken, it's very likely to be SVT. If the heart rate was 190, it really could be either, and then it depends on the circumstance it was taken in. But certainly in our office, we're seeing more consults these days based on biowearable devices that kids have these days. So Fitbits, Apple Watch, where they're detecting asymptomatic elevations in heart rate or somewhat symptomatic elevations in heart rate and are coming in because of that. So, but those ranges are, I would say for SVT, typically in the school-age child, 180 is on the slower end, but certainly 200 to 260 or 270 would be common.
Now, I can grasp and understand why you would do ablation in a child with WPW or an accessory pathway. My assumption is you're ablating that pathway. You no longer have it. When you have a normal-hearted child who doesn't have the accessory pathway, who's in and out SVT, you said you could do ablation of that. What are you ablating?
Sure. So if you look at SVT in general, and again, paroxysmal reentrant SVT in kids, the two basic substrates are either there's an accessory pathway present, so-called extra wire, if you will, that connects atrium to ventricle and allows electricity to bypass the normal conduction system. If that accessory pathway conducts in the forward direction, where we can see it on an EKG, that's what we call Wolff-Parkinson-White. But there are accessory pathways that don't have any forward conduction, and they only conduct backwards. If you will, they're one-way streets only going from ventricle to atrium. So the good news is that accessory pathway doesn't have forward conduction, so will not have a sudden death risk associated with it, but it can precipitate SVT because electricity can go down the AV node, up the accessory pathway, and back down the AV node, create a circuit. So accessory pathway mediated tachycardia is one substrate for SVT in kids, and the second is what we call AV node reentry tachycardia. It's a circuit around the AV node. So the overwhelming majority of us have an AV node and his Purkinje system, and within the AV node, or feeding into the AV node, we have a set of funneled wires, if you will, is how I draw it for families, and that's called the AV node fast pathway, and that's what feeds into the AV node, and that's what 99.9% of us have. About somewhere between 25 and 40% of the adult population has a second set of wires that feed into the AV node, and that's what we call the AV node slow pathway. So it's a second set of funneled wires that also feed electricity into the AV node. So when you have two wires in the same system, you can set up a circuit. And so AV node reentry tachycardia is a circuit between typically the slow pathway and the fast pathway, and that's what creates a substrate for SVT. And these two substrates, accessory pathway-mediated SVT and AV node reentry tachycardia, account for somewhere between 95 and 98% of SVT in school-age children and teenage children, okay? So these really are the two overwhelming substrates that we deal with when we're talking about paroxysmal arrhythmias, paroxysmal SVT in kids. And so when we go in there to do an ablation, we are determining, do they have what we call dual AV nodal physiology? Do they have two pathways entering into their AV node that would give them the setup for AV node reentry? Do they have evidence of an accessory pathway? And then during the ablation, we pace their heart from different chambers and we try and provoke their SVT to see what it looks like. And we typically can do that. And so then we can see, do they have AV node reentry tachycardia? Do they have accessory pathway-mediated tachycardia? As you said, when we ablate accessory pathway-mediated tachycardia, that accessory pathway is completely extraneous, completely unnecessary. So our goal is to eliminate it completely. With AV node reentry tachycardia, that second AV node pathway, the AV node slow pathway, is often intermingled a little bit with the fast pathway. So we do our best to interrupt the circuit. We recognize that we don't always 100% eradicate the slow pathway, because in order to eradicate the slow pathway, we may have to infringe upon the fast pathway. We don't want to do that. We always want to preserve the fast pathway. So our goal is to interrupt the circuit and prevent the formation of the circuit by ablating along the slow pathway, and that way hopefully cure the SVT.
And am I right in that for ablation, the child has to be at least 15 kilos for you to be able to do it?
So the 15 kilos comes from the idea that, and the bar keeps moving down as technology advances. Once upon a time, it was closer. I think people were using around 25 kilos, but certainly there has been literature in the last few years looking at the safety profile in ablation, and guidelines written jointly by the Heart Rhythm Society and the Pediatric Congenital EP Society have used 15 kilos now as a cutoff, as a recommendation for elective ablation, because the idea is the incidence of complication seems to be partially related to size. And so if you have children who are smaller, you have a higher chance of having a complication. What this means from a practical standpoint is, for most of us doing pediatric EP, we won't recommend a routine ablation for a child if they're very small, as long as you can control their arrhythmias with medical therapy.
Okay.
So the times that we contemplate doing ablations in extremely young children, even infants, would be if they are having life-threatening SVT that cannot be controlled with medical therapy. And so in infant, or in the setting of congenital heart disease where surgery is going to take away the access to where the substrate for their SVT is, and you need to eliminate it before their surgery. But if you have a 3-year-old who's small, who perhaps is 12 kilos, if they can be easily controlled with medical therapy, I would say the general approach would be to leave them on medical therapy and allow them to grow, to let them get a little bigger, because there does seem to be some relationship with size to complication rate. But if that 3-year-old is on multiple antiarrhythmics, failing therapy, in and out of the hospital, that's a discussion we can't have. It's not a technical impossibility to do it less than 15 kilos. It has to do with a risk-benefit decision on potential for complications and how easy your alternative is, whether your alternative is working or not.
I think the only thing we have left, because we've kind of discussed the mechanism of SVT and just now, and we could talk a little bit about vagal maneuvers and then kind of wrap up, as long as you're okay.
That sounds great. And I think the other thing we can touch on is just sort of the acute management in the hospital or in the emergency room, because that's something people may encounter. So vagal maneuvers, there's many that are written, right? We talk about in infants, we can talk about a gag reflex or doing a rectal temperature. You can try and simulate sort of the bearing down in an infant by sort of squeezing on their stomach. But the thing that I have been trained on, and I've had families tell me it works really well in infants, is to flip them upside down. Okay? And so essentially you cradle your infant hand over head as if you're sort of looking at them in the face, and then you sort of drop them down in front of you, holding them, cradling their head, and then bring them back up again. And that seems to work very well. The other thing that's mentioned in infants a lot is ice to the face, that sort of diving reflex. Personally, I think it's kind of cruel, right? Because you have to use a really cold ice bag or a bag of peas or something frozen, and I don't think anybody would like that startling effect, but certainly it can work. I think the two I would personally use most commonly would be either the flipping upside down or the rectal temperature to try and simulate it. What I counsel families on is, if your baby goes into SVT and you're at home and you've calmed them down and you're sure it's SVT, you should try to get them out with these vagal maneuvers. Again, they will tolerate it for quite some time. Now, obviously, at any point in there, if you think they're looking bad or not appearing well, then of course bring them immediately to the hospital or call an ambulance. But if you think they look their usual self, but they happen to be an SVT, if you've tried your vagal maneuvers at home, then, and it's been about 25, 30 minutes and they're not getting out, then go ahead and make your way into the hospital. I tell them point blank that when you take them out of their car seat to walk into the emergency room, check again to see if they're an SVT. Because if they seem to have gone out by now and you're comfortable that they're fine and they're not an SVT, you don't absolutely have to go get checked in the emergency room, because once they're out of SVT, there's not necessarily anything that has to be done in the emergency room that you need at that point. For older kids, similarly, I say we talk about bearing down like you're trying to have bowel movement. One of my mentors once taught me from his personal experience, you make sure you tell the kid not to actually have a bowel movement there when they're doing that. The other thing is to blow on a straw or blow on a pen. So you basically hold a straw, and what I show them in the office is cover the end of it, or hold a pen like pretend it's a straw, cover the end of it. And what I say is I want you to blow on this like you're trying to blow out a candle that's on a table over there 5 feet away. So I want you to blow really hard, and you have to hold the breath. You can't just, it's not a quick blow, it's a blow and hold till you sort of get that red in the face kind of woozy experience. That's what you want them to get to. But again, in older kids, the thing that families tell me works the best is going upside down. And so kids either doing a handstand or a headstand with some assistance or up against a wall to make sure they don't fall over, or you have them lie down on a couch or lie down on a bed and they flip their head over the side backwards, okay? And the families who I have the privilege of taking care of who have SVT, the kids tell me universally that works better than anything else. And so that's what the number one thing I counsel them on. I've had some people tell me that in the ER, they told them to do that while they lifted their legs up, and I think that's fine too if you have a person to do that. But again, many kids can do the flip their head upside down off a couch or off a bed quite easily themselves, and the patients I have who are school age and development and normal are very savvy at doing that, and that they can do it very easily. So those are the maneuvers I teach them. I tell them also that if you're trying this at home and it's not going away, after about 25 or 30 minutes, you might make your way into the emergency room. I tell the parents when you're driving in, if your child says, oh, it's gone now, then pull your car over, double check, make sure they're fine, then you're welcome to go back home, because there's not anything in the emergency room you need other than to get them out. And if they're already out, you don't necessarily have to be there. Obviously, in either case, with infants or with school-age children, if the parents are not sure whether they're out or they're worried something's not right, of course they should get them checked out. But if they're positive at that point that they're very comfortable, then that's something they can do and go home. Briefly to touch on sort of acute management in the emergency room or in the hospital if you're on the floor with a patient, if they're an SVT, in the lecture I give to our fellows about this, what I say is the number one thing of all is assess for hemodynamic stability. And again, most kids with structurally normal hearts and normal function who go into SVT will be hemodynamically quite fine. Parents will tell you, yeah, he looks just like himself. It's just that his shirt's kind of bouncing real fast, and you can see it in his neck that it's real vibrating real fast, but otherwise he looks totally fine. So if they're hemodynamically stable, then you have time to get them out. The other thing I put in my lecture slide, I always say, check your own pulse first, because it is sort of a nerve-wracking experience when you walk into a room and a kid's heart rate's going 270. It can be the case, depending on where you are, that many providers around will be very anxious about that, and people will be sort of worked up. And so make sure you're the sort of experience of calm when you walk in. The first-line agent, if vagal maneuvers have failed for us, is generally adenosine. Remember, adenosine is a very short-acting medication. It has a half-life measured in seconds, somewhere in 6 to 10 seconds. It's an excellent drug for terminating tachycardia because SVT typically involves the AV node, and adenosine will administer and cause temporary AV block. You have to know the side effects with adenosine if you're going to give it. And so the side effects really have to do with, number one is it's a vasodilator. It causes a brief hypotension phase. Number two, it can cause bronchospasm. So if kids are in status asthmaticus and receiving, say, continuous albuterol and magnesium and all sorts of therapies, I do have a little pause of how much adenosine I give them. I don't withhold the drug entirely, but I recognize that I probably want to start at a very low dose to minimize, because I believe there is a dose-dependent effect to the bronchospastic component. And then I always say that adenosine can precipitate any rhythm disturbance just like it can stop SVT, so I never give adenosine without a crash cart present because I know that something could happen. The last patient to be aware of is patients with transplanted hearts are exquisitely sensitive to adenosine, so you have to reduce your dose significantly, probably by a quarter, because they'll have a very prolonged effect for adenosine. You give adenosine with a stopcock, and you flush it, you chase it with saline flush with a decent amount. So usually for most kids, I'll give it, for a baby, I would give at least 5 cc's. For an older kid, I give at least 10 cc's of saline flush chaser. I hook it up to a stopcock and put the adenosine on one end, the saline on the other end, hook that up to their IV, adenosine, turn, flush, off. And so you got to give it rapidly. If they're in SVT and they're hemodynamically stable, then you should get an EKG while you're running adenosine, because there's a lot of useful information we can see as the tachycardia stops to help us figure out what it might be and help us counsel families on what it is. And then, the other thing about SVT that's interesting is if somebody's in SVT and hemodynamically unstable, then they should be synchronized cardioversion. They should undergo synchronized cardioversion, and really that's the direct management.
Now, for hemodynamically unstable in, let's say, an infant and then in a neurodevastated older child, you're looking for signs of cardiogenic shock. You're looking for hypotension. You're looking for, obviously, tachycardia, the child to be pale, lethargic, not responsive.
Correct. Poor perfusion, poor capillary refill, poor distal perfusion, biochemical signs of poor output, high lactate, compromised perfusion that way. But those are all things you look for. And so, if they're hemodynamically unstable and in tachycardia, the line I use with our fellows is if somebody's in narrow-complex tachycardia and you're not sure it's sinus and they are unstable, it is worthwhile to do synchronized cardioversion because they may be in a tachyarrhythmia, and that synchronized cardioversion may be what gets them out and helps restore hemodynamic stability. If someone's in sinus tachycardia, now, we say sinus tach has a peak of about 220, but in the right setting, I've seen sinus tach be at 240 to 250 in the right kid, right? So if a toddler has a temperature of 104, is extremely dehydrated, could they be in sinus tach at 230 or 240? They could be. But the good news is, if done correctly, doing synchronized cardioversion on somebody in sinus tachycardia, you're not going to hurt them. So what I tell our fellows is, if you're not sure that they're in sinus rhythm, or that it's sinus tachycardia, if they're in a tachycardia and they look poorly, then synchronized cardioversion may be life-saving, and you're unlikely to harm them if you do it correctly. So if you can't be certain, then you should consider that.
And then if we're on the floors and a child's in a rate of 240, 250, it's a 3-year-old, and they're happy, and they're playing, and they're fine, I don't have to rush, grab the crash cart, grab the adenosine, I can call cards and say, I think this is SVT, the child looks really well. They're here with bronchiolitis or gastro, and we've rehydrated them, and we've done all the appropriate things, but he's still at a rate of 250. As a narrow complex tachycardia, I can wait and call you and have you come.
Absolutely. You can. In that scenario, what we'd want to say, hey, listen, we're getting an EKG hooked up, we're doing this, we're getting adenosine drawn up, but can you come see him because I think this is SVT? And so for those of your listeners who have cardiology available to them in that fashion, we love that because from our perspective, where I trained, certainly we were there for administration of adenosine most of the time in the emergency room, and I found it very advantageous for me personally, education-wise, and also for us to work as a team of individuals between the emergency room and cardiology to be able to sort of offer families that therapy and then counsel them on what comes next. And so, in the hospital setting, I would say if you have a cardiologist who's available in-house to you, then getting those things ready while you call them is perfectly the right strategy because, as you said, the kid's fine. So if the kid's fine, that gives you some time to get these things together to make sure we're all in the right scenario.
Okay. And if I'm in a setting where I don't have a pediatric cardiologist, and I'm in a community hospital, but there's an adult cardiologist, would you say they'd be helpful during a situation, or is the differences so vast?
No, I think in general, yes, the biggest difference is dosing, right? So in the adult world, we talk about for adults, the adenosine dose might be 6 milligrams as a universal to start for most adults, and that's fine. In kids, the adenosine dose we typically use is 0.1 milligrams per kilogram. Up to 0.3 is a typical dosing. We typically will cap it at 6. So if you're a big enough kid that you're sort of adult size, we'd say we'd start at 6 if you're an awake person. But the remainder of it, I think, would be fine, right? Because the remainder of the SVT is that what they're used to seeing. The rate is going to be much faster than they're used to seeing in their adult patients, and that's one of the pitfalls is how do you know whether it's SVT or not? But for them, 240 or 270 is going to be a no doubt SVT to them. And yes, if you're in a place where that's the only cardiology you have readily available to you, I think it'd be perfectly fine and be absolutely a help to your listeners.
So just to kind of recap what we talked about, Gaurav. So we've talked about infants with we talked about SVT and the mechanism and the accessory pathway and AV node entry tachycardia. We've talked about infants and how they can present in shock, in lethargy with poor feeding, mottled appearance when they have SVT for a period of time, or it can be accidental. And we've talked about how in infants you would typically medically treat, or depending upon how bad the SVT was, you would try to medically treat. If it was very bad and they were sick, you would, of course, ablate. We've talked about ablation and the kind of pros and cons and the side effects of those. We've talked about the medical therapy of propranolol and digoxin. We've talked about how it's different in older kids, how they'll usually be able to say something, whether it's point to their chest if they're very little, or say, I feel it's like a beeping or something's different. And then for younger kids, it may go away. For older kids, it typically does not. Eventually, they will probably need ablation. We've talked about adenosine, when to do synchronized cardioversion. I mean, I think we've covered a good portion. Did we miss anything?
No, I think that's a lot of what the SVT that you'll see either in the emergency room or in the urgent care or in the hospital. And I think those things will be good things that you can counsel your patients on and guide them. The other thing to know from a practical standpoint that comes up in my practice a lot, though, is that when kids have SVT episodes, if they're out there, they're playing basketball, they have an episode, they come over to the sideline, they get themselves out. I tell them if they get themselves out of their SVT and they feel back to normal, they can go right back to doing what they want.
Is that right?
Families appreciate that, and I think that sometimes that's not always the case. And so I've had families tell me that, the school wants me to take him home because he had an episode of SVT. And I said, look, if he's out of his SVT and back to normal, he should go back to school the rest of the day. And we don't want him missing school. But those are some of the factors that go into what we decide to do for kids with SVT because of those environmental factors and people being comfortable about it.
Okay. Well, I think this is a great place to we'll do one more joke. We'll stop and we'll get out of here. And then, so I'll go first for the joke. What do you call a pig who plays basketball?
What?
A ball hog.
Nice. All right, my other one, and if your audience hasn't figured out, I'm a Star Wars nerd. So in the Star Wars universe, what computer program do they use to read their PDFs?
I don't know.
Adobe One Kenobi.
Now, I want to say, Gaurav, thank you very much for coming for doing this. This was great. You did most of the talking, but I really appreciate it. I thought it was very educational, and I hope you'll come back and finish the Dysrhythmias with me.
Looking forward to it, Tony. Thank you again.
I want to wish everybody a happy Thanksgiving. I hope you all have safe travels and enjoy turkey, unless you're vegetarian, and enjoy whatever you're eating. Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at Tony, Tony.Tarchichi, TARCHICHI, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.